Okay.
I don't know if anybody can hear that low hum in the background. It's my dishwasher. It's on its last legs.
No,
No.
no,
Nope.
no problem.
You ready for the public?
Sure.
All right.
Just running to grab something off the printer.
Okay. Okay, so I think we're going to go ahead and call the meeting to order. Welcome everybody to the Board of Health. I'm going to run through the agenda tonight, and so let's sort of dive right in. We're going to first review the minutes from our last meeting on January 6th and get a vote for approval for those. Then we're going to hear the long-awaited work of MAPC in terms of their assessment of the health department. Been working closely, Mark has been working closely with Kerry and Aday, and we'll be presenting along with Pat Maloney. We'll hear any Reading Coalition updates if there are any from Kevin. Then we'll get right into the monthly report with Aday and the public health nurses. And then we're going to move on to doing what we said we would do 4 weeks ago, which was to review the mask mandate order and look at some data, see if we want to continue that. There is a waiver request by the folks from Simply Fit and Fun around a waiver for the mask mandate. And so we'll hear that. And then we'll go to public comment and then wrap up with next agenda meetings and any other comments there are. So that's it. That's it for tonight. So in terms of the minutes from January 6th, were there any revisions, changes, suggestions at all?
I didn't see anything.
Nope.
Okay, good. So a motion to approve the minutes from January 6th. Do I hear a second?
Sure.
Paula, second. Okay, roll call. Carrie?
Yes.
Paula?
Yes.
Rick? Yes. So those
Thank
minutes
you,
are.
Jackie.
Mhm.
Wonderful job
Thank
as
you again,
always.
Jackie.
Always.
Concise and well done as usual. All right, so let's, without further ado, let's move on to Mark and Pat and hear what their last 4 or 5 months has been. Go ahead, Mark.
Yeah, hi. Yeah, so good to see you all again. Yeah, Mark Fine. I direct the Municipal Collaboration Program at MAPC and have been working on this project alongside my colleague, Barry Keppard. Barry, you want to just say hello real quick?
Everyone, nice to see you. I'm Barry Keppard. I'm the director of the Public Health Department at MAPC.
And obviously,
Barry,
Pat.
welcome.
Yeah, no, good to, Barry's been, we're closely partnering on this, and obviously Pat Maloney we have been using as our subject matter expert, and it's good to have Pat joining us here today. So so just a little background on where we've been since we last presented to you. That was in November, and at that point we presented our initial findings from our review, and we had done interviews, we had done data collection, we had done kind of the peer community review, and had presented the findings, from that work to you at that point. Subsequently, since that time, we've been doing further work, mostly on kind of the assessment elements of the work, but also on some initial recommendations. And we met with Ade and Kerry in December to share thoughts on that assessment and some of our analysis there. Both on the department, but also on just the wider health services that Reading possesses, because I think the review is encompassing both elements. And, so that was in December. And since then, we then have met with Ade again to run through some of the, just kind of check in with him on some of the information relating to the health department, some gaps in our knowledge base that we wanted to fill. And that was really helpful to have Ade's views. And we've then pulled together some recommendations to kind of go alongside with their assessment. So tonight, what we mostly want to focus on with you all is that assessment, of health services and those initial areas of focus and recommendations. And then we can talk, after that about some of the next steps we'll take to pull all this together into a final report to the board. So I will share my screen at this point and we will go to our slides. Any questions or thoughts before we do that? Cool. So here everybody see that? Good, yes. Great. Well, yeah, so I mean, the first thing we wanted to just, touch on is some of the recent progress on health services that have been made in Reading, because, even in some ways, since we started this work and started having conversations with you all, a fair amount has moved forward. So, one of the things we wanted to reference is just that, the budget, the town has spent considerably more resources on public health over the past 5 years, and especially in the last few years. One, another factor is a new director is in place, and Ade has taken that role. And I think alongside that the health department has been given departmental status, and potentially new offices in the public safety building are coming. And I think another big thing to note is just that, the nursing services have been, expanded beyond where they were a few years ago. So a full-time nurse has been hired alongside the part-time nurse you had before. And I think to speak to sort of those things that have happened outside the health department, additionally, like mental health supports have grown in the community with the hiring of a social worker within the police department. So those are some of the areas of progress. And I think what we've kind of been, thinking about it in a lot of ways in doing both the assessment and, thinking about the recommendations is kind of what the task ahead. And I think a lot of it's really leveraging the progress you've made, to position the town and health department to meet recommendations from, the special commission, which is one kind of, the body of work that they've looked at to like assess Massachusetts health departments by, and also some of the national standards like foundational public health services that's also used as kind of a benchmark by which to, assess public health departments. So we will speak to all of that as part of our assessment today. And I guess, one of the things we also want to just capture and is just kind of place the health services kind of appropriately within the municipal government and, represent, I think, some of the changes that have been made. So obviously, we wanted to capture the kind of public health and safety sort of departmental structure, kind of oversight and collaboration that you'll see with fire, police, and the health director. Obviously, the health director, works directly to the local board of health as well. And, I think, we tried to then touch on those areas, within these departments where health is also part of the mix. So fire, obviously, they have emergency medical, the police with the substance abuse coalition work, community services, both on the elder side and veteran services, and the important work that the senior case manager does and the nurse advocate does. And then, we also touched on the schools, where they have 9 school-based nurses as well that have worked closely, certainly through COVID with, with the public health nurses in the health department. And then I think the other piece of this, when you look back on the health side, just representing the staffing there. So the nursing, staff that they possess. We know the full-time inspector position is still vacant, but it sounded like good progress was being made on that hire. There's a part-time admin role. And then there's a number of services where they're contracted functions, food inspection is one, tobacco, through a shared regional effort, Animal control is also shared regionally, and that's true for mosquito control as well. So, we want to, portray, health services in Reading appropriately and represent some of the changes that have been made of late. So when we started thinking about the assessment, some of this was like, well, where's the staffing kind of stack up against, some of the national or regional parties that, kind of look at these things. And one was, the National Association of City and County Health Officials, does kind of put out some, recommendations for kind of staffing levels for health departments at different, different kind of population levels. So, that's one way to look at it. I mean, Reading has actually grown in, the last 10 years. So, it is over 26,000 people now. And, that kind of places it a little higher on this kind of NACHO, gradient. And, the recommendations there, as, are for, a leadership role, a public health nurse, 2 environmental health workers, and a full-time admin. So when you think about we just wanted to think about the department in the context of that. And obviously the department's, the director there, the nursing staff, you've obviously, really expanded that capacity. Sanitarian, we know that position is vacant, but that's something that is looking to be hired. And then the admin role is a part-time position. So yeah, I mean, it might, I guess in comparison, this is one way to think about, are there places where, the capacity needs to be looked at? This was one, framework for us to do that with. And I'll move forward to some of the others.
Can I ask a question just on that previous slide?
Please do.
What would be the definition of an environmental health worker? Is that just an inspector, or are there other job definitions that would fall under that?
I mean, I think we've taken it as sanitarians, but Barry, yeah, if you have something.
Yeah, I mean, actually, Pat is probably one who knows that, and I don't mean to put you on the spot, Pat, but in kind of given your work in environmental health, you could probably speak well to that.
Sure. Yeah, the term sanitarian or public health sanitarian is it's one of the older terms for the environmental health position. What's currently being used now is environmental health specialist. So persons can get the certification and credential as a sanitarian / environmental health specialist. And the environmental health specialist, I think, is more rounded in its definition, where you'll see individuals who can do air quality monitoring and hazmat assessments and things of that nature. But the sanitarians are trained also in that. So it's possible that a recommendation to evolve with the current terminology might be in the works here.
And Rick, to your point, and Pat can correct me too, it is a catch-all for essentially people who are doing housing inspections, food inspections, beach, recreational, pool, hazmat. So it is an expansive field of a lot of different services that essentially looking at those kind of physical, like hazard driven risks that people could run into. So it is a bit of a catch-all, I think, as Pat was describing.
Thank you.
Yeah, so thanks for that question, Doctor. And yeah, I was going to hand it over to Barry to maybe speak to the special commission. This kind of summarizes that, but then also kind of how, some of the things to take into account in assessing the department, with the special commission's recommendations in mind. So Barry.
Thanks, Mark, too. And I'm going to build off something kind of Pat said as well, too, is that what we're seeing in terms of the public health workforce is an evolution in terms of what should really be the desired credentialing or experience that someone is bringing into the jobs as well, too. So part of the special commission, so is the Special Commission on Regional and Local Public Health, and that was completed the report in 2019. But what they talked about is that essentially we really need to bring, at least kind of based on the landscape of reporting of the way public health is occurring in Massachusetts at the local level, there's really a need and a drive to kind of move up that kind of basic, whatever the kind of floor is for where people are. And so they set forth a series of credentials, to your point, Rick, earlier, the essentially environmental health staff, but also essentially what certifications should public health nurses have, health directors, health agents, other folks who essentially kind of playing kind of critical roles within it, actually even speaking to some of the things that they would hope kind of board of health members would do in terms of both kind of professional development and kind of enhancing their understanding around some of these categories. The other piece that they're really driving on, and this is probably going to come more for the state, but something for cities and towns to be aware of, is kind of more regular satisfaction of those requirements around data reporting. They aren't all fully spilled out, but essentially they speak to ability to kind of speak to permits that are being done, inspectional capacities, if there's certain variances that are being given or recorded to certain kind of public health actions. All of that is essentially kind of record keeping, but other things that the state either requests or essentially could request as part of understanding where public health departments are performing their tasks. And then ultimately, and Mark alluded to this earlier, is that there are frameworks at the national level of what health departments should satisfy to have within themselves. You may have heard of the 10 essential public health services. That's a framework that's used. Another framework that is used is the foundational public health framework too, and it speaks to a set of capabilities and capacities that a health department, but in particular in collaboration with others they're working with. So like this would be demonstrated in Reading, that those things are present or being built out. So again, that they can get at both the risk factors that residents may be facing on a daily basis, but also beginning to think about other contributors, other foundations of health that really speak to mental wellness, physical wellness, wellness as people's age, and speak to those particular pieces as well. Now to go to the next slide, Mark. So one of the things we wanted to start out with, again, thinking about, again, part of this is like, where are we thinking about the special commission recommendations and really getting to those core public health services? How are those pieces being met in the town itself too? So looking at essentially the current positions and how they're staffed, what the credentialing often recommends is that, I'm sorry, Mark, you can, speaks to essentially credentials that people should essentially have or probably expected to have upon hire, but then also the recommendations for credentials people should have within a certain period of time in those areas. So you can see on the left in terms of credentialed staff, suggesting essentially what people have in their role and the credentials people should be moving towards in those types of things. And in many places, what's happening now is being met by the town, but there are certain areas in certain positions where progress can be made around those particular pieces. Kerry called this out when we met earlier, but there is a recommendation too that Board of Health members participate in the Foundations of Local Public Health course. Not a requirement, but a recommendation. And that's a training that's offered by the local Public Health Institute coming out of the BU School of Public Health. On the right side, you can see, speaking to, again, those activities that boards of health and health departments should be satisfying as part of their kind of daily routines, inspections and permitting, how you're record keeping around complaints and enforcements, participation in infectious disease reporting through the MAVEN system. And what we can see essentially, I think, is that there was activities that the health department engaged in, recording through Excel, through digital, through electronic tables. But again, looking at Ade's leadership and what Ade is beginning to bring to the department is a transition to more electronic permitting, places where essentially, again, permitting and inspections can be done on site, can be recorded, and then can actually move the way into a system. So again, this is moving in that direction of the data and reporting I think that the state would be looking for. And that would also eventually kind of lead to the efficiency at the local level for the health department to participate and do that work well. This is the framework for foundational public health that they use. And as I spoke to, like along, if you look along the vertical, or sorry, the horizontal axis of it, it talks about kind of capacities that health departments should have. Can they address communicable diseases, chronic diseases, environmental public health risks? Are they thinking about other things, maternal child health, access to healthcare, vital records? We know essentially that the way health departments are set up in Massachusetts, they're not going to get to all those capacities. And that's a place where both kind of partnership and work can really kind of help make those things happen too. So relationship with hospitals, other program providers, things that can be partnerships within the work. When it comes down to capabilities, that is really speaking to stuff that is really kind of hoped for and aimed for to be within a health department too, is their ability to kind of keep track of data and kind of health conditions within the municipality. So the assessment part of it, the emergency preparedness and response, so thinking about both kind of acute crises, but also essentially what we've been going through in the pandemic, being able to do really good public health communications. And I think there's examples of that on the Reading Health Department website. Are they involved in policy making, things that I know you're all going to talk about later tonight too? partnership with community organizations, and again, competencies in terms of operations of the health department too. So one of the things we also wanted to look at is kind of where does the health department sit now in regard to those foundational health services. How do you go to the next slide, Mark? So here's one way, essentially, again, again, this is all going to be coming to you as a PowerPoint you can look at closely too, but you can see what we began to look at is what are the activities that are happening in with the town. Something we took from our last conversation in November was essentially we're thinking about health services. How's that happening in the health department, but also in the partnering departments and others. And you can see here work that's occurring in terms of assessment, YRBS, connection to the Winchester Hospital Community Health Needs Assessments, ways you can know about kind of youth and chronic diseases, preparedness that's happening. We know that kind of the nurse lead that's coming out of the health department to do that work. We know you all have engaged in strategic planning in the past, but also thinking about specific health issues. Like I mentioned earlier, the multitude of communications I think that you all have been developed through this work, particularly again, stuff that's been related to COVID-19. Partnerships that exist. And again, organizational competencies is an area again that we can explore a little bit more, but that's something under foundational work could come a little bit later. And then again, too, this is speaking to the capabilities part. And you can see there's a lot of strength around communicable disease. Again, credit to the nurses and the work that's happening there, to environmental public health work, again, contracted work, inspectors you've had in the past, programs you've had around kind of youth vaccinations. And then again, connections you all are doing on the clinical side, a lot of that having to do with vaccinations and screening. One area that, again, that seems like it might be an area that I think we've heard from you all, but it maybe shows up a bit here, is that some of that chronic disease and injury prevention work isn't happening at the level of some of the other works that are within the kind of the town and coming out of the health services of the town at the moment.
Thanks, Barry.
Thank you, Mark.
Yeah, so I mean, I know we're throwing a lot at you, so feel free to ask questions at any time, but you know, so that was kind of the assessment we've done. And I think before we talk about some of the recommendations that we have and kind of areas of focus, we want to just refer back to some of the priorities that town officials mentioned in the interviews and other conversations we've had, and that certainly have come up with, you know, the board as well. And obviously, I think, you know, we identified, you know, 6 of them that were priorities mentioned. You know, mental health seemed like the top issue for everyone. It was the first one on people's tongues when we asked them about it. Improving coordination with other departments on emergency response, I think, was another, you know, another area where, you know, there was interest. More health planning, assessment, education, and awareness was seen as important. I think they wanted to see the health department play a bigger role in, you know, in kind of health leadership in the community, and enhance communications to residents on health issues. I think there was a desire to build code knowledge and enforcement capacity, and you know, you know, enhance those skills. And I think, you know, obviously some of the hires that you're looking to make around sanitation and environmental health are aimed at that. And I think, you know, people have, you know, there was a desire to see more health leadership from the director and the department. You know, and lastly, like, just, you know, I think, you know, building the emergency response skills of the department staff themselves to play that role was also kind of, you know, I think kind of dovetails with the improving coordination with other departments on emergency response. I think people wanted to see those skills built into the health department, and having the, you know, health department have the proper training and abilities to do that. So, I mean, in between, we just kind of pose some of those type of questions, you know, that have to be considered as, you know, the town is looking at, you know, addressing some of these issues. You know, one, you know, on the mental health and coordination, like, what is the best way to strengthen those partnerships with fire and police leadership and staff? You know, obviously that's important nexus on health, especially on mental health, because of the capacity that the police department has built. You know, then I think, you know, recruitment was another area. You know, just how does the town recruit skilled inspectional staff, and what tools do they need to thrive? You know, such as data systems. I think, you know, ADE's already making some great progress on that. So it's something that is being addressed. And then, you know, is a health needs assessment a further step to engagement on health improvement? You know, is that a way to engage the public and look at, you know, what are the community's priorities, and continue to keep that fresh? So these were, you know, we wanted to, you know, relate back to the priorities that people expressed, and think about, you know, both the assessment and recommendations in light of that.
Hey, Mark, real quick on that last slide.
Yes.
Can you expound more on the more health leadership from the director and department, what the vision of the officials were thinking? I know obviously we have, we're pretty new to having a director here in town. So I'm just curious to see what their vision of that was. Do you
Well, I
have
mean, I think,
more on it?
yeah. Well, yeah, I mean, I guess it probably came up in different contexts with different people. So it was definitely, I would say, certainly, from the public safety leaders, I think there was a desire to have the health director kind of at the table with them, thinking about the issues they need to address collectively. And I think when, in some cases, when, the community was formulating its COVID response, and obviously that was tough for everybody. I think wanting to be able to come to the health department as a leader, and as kind of the maybe the, a respected party, in such circumstances was something that was mentioned. I mean, I think other parties would definitely love to have the health department at the table more often. I think, certainly, the Substance Abuse Coalition folks could kind of express that as an interest. And I think, speaking to just kind of some of the other things around like the education and awareness, I think having the health department, play a role in some of the communications around health issues, I think was something that, people found as worthwhile too. So that was, that's kind of where we derived that priority from.
Okay.
Does that make sense, Kim?
It does, yeah. And with all these 6 that you identified, you have it broken down a little bit more that you could give us, it'd be helpful. Like even just hearing your explanation of that one particular one is very helpful.
Sure. We can, I mean, we obviously, behind all these was a lot of note taking and information gathering. So, I mean, we do have that. And I think the final report would reflect some of that too.
Okay, great.
And if I
Thanks,
can
Mark.
add to that, it was clear from those interviews, they were looking to build that team so that the health director is part of that team, whatever the challenge is. So with the COVID, as was said, to be at the table and to be part of that team to develop the strategies and to move forward with whatever challenge that is. So, and that's a good thing. I think when you have everybody working as a team on that mission, that's a huge plus to get in the right direction.
Yeah, I agree, Pat. I think the board generally in wanting to hire a director had that vision exactly that you're laying out. And I know Ade's up to the task for it.
Yeah, and I mean, in talking to Ade too, I mean, I know like already like the incident command and, emergency, response meetings, and he's been very involved with those. So I mean, that's, a key piece of it.
Great. Thanks so much.
Yeah. And I coming back to one of the areas we had presented on to you in November. So obviously I think these were kind of important findings, was just some of what we saw as mentioned as the strengths and challenges that people identify. So, I mean, obviously, the strengths, the director position, the public health nursing, communications with an expertise of the Board of Health. So, I mean, the Board of Health was seen as a strength, the increased budget and the strong health programming outside the health department were all strengths. I think, when you think about the challenges, like we've just talked about department leadership and expertise. I think people have mentioned the number of Board of Health members as a challenge. With a 3-member board, it does create some issues. We did find, some, in talking to some peer communities, they did relay advantages to potentially looking at increasing the size of the board. And department communications, the regional connections, and then some of the staff turnover and kind of oversight on environmental health were some of the issues mentioned in those findings. So, I mean, now we'll come to just some of the areas of focus that we really wanted to think about in addressing some of the issues that were presented. So I'll hand it back over to Barry for that piece.
Thanks, Mark. So again, building up your question, Kevin, that again, what are ways that there can be a continuation or continue to support the kind of leadership and staffing and departmental capacity? A little of that relates back to the kind of credential and kind of the professional development side of it too, but also again, means kind of creating and figuring out where are those spaces locally that can be done to allow that to happen. We see ADE beginning to seize that. One of the things I would have added earlier too is that public health, unfortunately, sometimes is one of those things that has a lot of impact, but is often invisible. So thinking about kind of that visibility piece that also happens through leadership. Two is the kind of partnership piece. So again, both within the municipal department framework, building partnerships and strengthening those partnerships, which we see happening now too. But there's also opportunity both within the funding environment right now too, but also in terms of those kind of capabilities that a municipality may have, say like epidemiology and understanding of health. There's opportunity to build partnerships around those things, and that's a thing that I think could potentially really serve Reading well. Development, again, continue to build out kind of the skills of the department. I think particularly this would lay heavily on the kind of the environmental health side of it too. Understanding it's both a vacancy, but it's an understanding of an area too, where it feels like more knowledge, more capacity there could be a benefit to the health department, but also a benefit to other department capacities within the city. And then lastly, again, the kind of a communication piece too, where there are more opportunities for engagement, connection with residents, connection with businesses, to reinforce kind of the role that public health plays, not only in kind of in the protection, but also in the way it enables economic development, it enables healthy communities for residents who are younger, residents who are older.
Yeah, thanks.
Should I continue with these, Mark?
Yeah, you can, or I'm glad to as well.
Yeah, maybe I'll take the first two and then the next two over to you too. So on the leadership and staffing sides too, one, again, this would be, again, speaking to that need, and that's part around the inspectional services work. So again, really hiring someone who can move into that role, and ideally will have longevity with the town. The health department, the town was really great to invest in the person who was there previously, but we know they moved on too. So again, this is an area too where I think bring in somebody there too. This is an area too where, again, we look at health departments where essentially the comparable peer communities are, where I think you all want to be. It does seem that a full-time admin position is really, really kind of a way to kind of professionalize and help the department operate much more efficiently within the community, for businesses, for other departments within the town too. We see more and more health departments, and again, ADE is beginning to lead this, is moving towards a place too where you have a solution that's working through software too. It allows in the field reporting, in the field and kind of enforcement and follow-up activities, but it makes on the back end a much better process for record keeping, but also actually engagement for the residents to be able to look at, see what's happening with particular kind of applications that they may have to the board as well too. And then I think Mark alluded to this too. We've seen more flexibility and kind of growth within health departments when they've had a 5-member board. It allows 2 members to represent the board, engage with other boards and other conversations, engage with other kind of departments and other partners in the work as well too, without kind of running into issues around public meetings too. So it seems to be a change that's allowed kind of more activity to happen through the board, but also to be engaged in a lot more town activities kind of in a more substantial way. In terms of partnerships, again, we talked about being kind of within the town, but also with outside the town, essentially within town government, but outside of town government as well too. Thinking about this idea of continuing to have a health and public safety leaders group, some type of regular set of conversations that are happening between police, fire, health department, others that should be in the mix at the town in a regular basis to really build a strong working relationship. On a weekly basis, it may not make the biggest difference, but we know when curveballs are thrown, whether it's a pandemic or some other type of emergency, having those strong relationships is really vital. We've really heard and seen the difference in our cities and town where that trust existed between police, fire, and public health. The action and the speed of action that's been able to take in is really impressive versus places where it's been a little bit more of an unsteady relationship. The town itself could think about conducting a community health needs assessment. We've seen more and more towns doing this. It's a way to understand essentially kind of profile of older adults, the community at large, younger adults. You have some of that data already from the YRBS. Tufts Healthy Aging Collaborative also has a profile on adults over the age of 65 as well in the town. So there's some easy ways to bring that, but also a way to kind of build from those priorities, bring in additional grants, other kind of program supports for that work too. And then again, we're in an environment right now where a lot of cities and towns are engaging in shared service collaboratives. It's ways that they're augmenting their staff around inspectional capacities, public health, nursing, epidemiology, as well as other ways. Again, if they take care of those core services, being able to work on other things that they can offer to residents and to businesses in their municipalities as well too. So I think Reading was part of these tentatively, and that didn't quite work out in the short term, but there should be more and more opportunities for that coming from the Department of Public Health. Mark, I'll turn it over to you for the last two.
Right, thanks, Barry. Yeah, so I mean, when we speak about development, we talked about the skills and capabilities of department staffs. So one thing to think about with, when you're staffed up is to create a workforce development plan for the department, really where you're providing staff members with, professional development goals, I think aimed at meeting those special commission recommendations. And you don't always get to hire people with all the credentials and training that you might think they could use and benefit from. And I know probably in these times, it's been pretty difficult, with COVID to probably be able to spend the time, looking at some of that, but potentially, as things move forward, you will have more time for that, and having kind of a plan with each staff member to think about how they upskill, think about, are they, meeting some of the special commission recommendations, and trying to enable them to have the time to work towards that is important. I mean, I think, kind of dovetailing on the recommendations around partnership and regional collaboration, I think building those strong relations with health directors and personnel from the neighboring towns is really useful. I mean, sometimes those, if anything, those shared service grants, one of the benefits is just gotten a lot of peers together pretty regularly to talk. And I tend to think, you learn so much from your peers in these type of disciplines. In some ways, nobody knows how hard it is to be a health director other than other health directors. It's probably true for the public health nurses and for inspectors and others. Trying to build in some capacity for that to happen is important. And then, speaking to the emergency preparedness, points raised, in the priorities section, providing emergency preparedness and incident command training to all health department staff, and enabling the director to lead on health response, I think is really, really critical, and something I think, members of the board, including Kerry, have kind of mentioned as something they'd like to see happen. I mean, I know, like, for instance, Schwang, your nurse, she's leading the PEP coalition, the Public Health Emergency Preparedness Coalition, for the group of towns Reading works with in that, and that's great. But, there are some basic trainings, if they haven't taken them already, that could be worthwhile, and having a whole department that kind of understands at least the basics of kind of preparedness and incident command could aid the town, in responding to, further outbreaks of COVID or other emergencies. And then I think the professional organizations and regional public health partnerships that exist out there, is another thing to just try to make sure they have time to do that. I think, there are conferences and things that take place regularly, and, it's another place for peer engagement and learning to take place. So can be important going forward. I know time is always of a premium, but these are things to try to make time for. And then, lastly, on just communications, identifying opportunities for the health director and department staff to engage residents. I know that's probably, been difficult with staffing levels over the years, but now that the staff is growing, becoming more robust and has, Ade's leadership, I think there'll be more opportunities for this to happen. And I think kind of freeing the health director to, to take those steps on their own. We did hear comments before that, it wasn't always clear that health staff kind of had, the agency to, to lead on kind of health communications or do, active engagement. And I think they would like to, and have, plenty of good ideas for what they can do it. Yeah, and I think the next one is really like a communication strategy for the health department. That is something worthwhile to, consider. It's just sort of, what are the issues and messages that the health department is looking to, convey to residents. I imagine COVID's kind of dominated that for a while, but, it doesn't mean that other things are not, worth looking at as well. And then we did mention, providing cultural competency training for health department staff could be another area to enable them to engage with, a diverse range of people and populations in Reading, and kind of aid their ability to bring, people from all backgrounds, into those conversations. So those are among our recommendations. These are initial. We have behind this, there is a lot more written up, that will describe some of, what we mean. And that would be, a kind of key basis in the final report we would we would provide you. But yeah, I mean, just before we, just talk about some next steps, any questions on any of that or thoughts?
Carrie?
Yeah, not a question, but a thank you. I'm reflecting, thinking of where we were when I started in this conversation in July of 2020, and where we are now. And it's thanks to all of the people that I can see in my camera, and really, really gratifying to see. And thank you to MAPC and bringing on Pat as well for pulling together this information to help us continue on that path.
Yeah, thanks, Greg.
I think
And-
it's, I think it's for sure what you presented tonight is a very broad and yet adequate detail. And that's always important to get down to, let's say, these last few slides of exactly what, we could do to improve the functioning of the health department. It would be nice for the board members to be able to see, obviously, I would say from my perspective, I think you've, off the top of my head, I think you have covered the waterfront in terms of what needs to be addressed. And I know that with Carrie and Ade working with you, that's probably one of the reasons it's fully baked here. What I think we need to see would be for the board members to see at least, your final or at least semifinal, report with details so that we could actually sit quietly and read it and really think through it. And then maybe have you come back one more time if in fact, after further kind of deliberating and, we have any final, feedback or comments or suggestions. That probably would be the process. I mean, I could see myself personally, oh, here you go. There it is. So where in the initial, the recommendations component. Okay.
Yeah, I mean, Doctor, I would say, I think what you just laid out kind of dovetails nicely with what we were thinking the next steps would be too. Because, we wanted, in some ways, we've been doing these presentations to the board, but our next move would be to draft the report and provide that to the board, in writing. So you guys, and with the chance to read it and comment on it, and do that. I think, our aim would be able to get that to you in, before mid-March, and then give you time to comment. And then we would come back, we could take those in, come back before the April board and, with a finalized product and discussion with you all. So if that, and yeah, the report will be, we'll be able to provide the detail behind some of the recommendations, the assessment we've described, and even the findings that we had presented earlier. So that would be our, our aim over the next, 2 months.
Great minds think alike.
Yeah, I mean, we had hoped in some manner to, we were thinking about like, hey, can we get back to you all by the Board of Health in March? And I think actually that would have, one, it might not have given you enough time to review it. And two, a member of our team did depart, Elaine Zhang, who you might have met and talked to. So we are, a little shorter staffed than we were, but we have the capacity to, pull this off amongst Barry, I, and my colleague Brian. But I think that would be a good timetable to enable you to review it, engage with the final report, and then provide comments and feedback in advance of a discussion at the next board, at the April board. If that makes sense. And we would, obviously make sure, that Carrie, Ade, and others would be, closely involved in that alongside the whole board. But we'd like the whole board to be able to see the report before it is in any final form. So.
Thank you all for your tremendous effort on this. Carrie and Ade and you folks at MAPC, Pat, all of you, thank you so much.
Sharon, but Yeah, no, I mean, we've been lucky to have, Carrie and Ade providing us good, kind of good, feedback throughout, the steps we've been taking, and Jean before that too. So
Yeah,
we have had, and having Pat's kind of knowledge and experience has really been invaluable to us as well. So I think we got a good team, and we will work towards, the plan we've laid out. And I think we'll be able to produce a final report that I think will, provide the board, provide Ade and the department with, and the town in general with, a strong roadmap to take things forward. And we also do know the new town manager very well.
Oh,
We know Fidel,
Yeah.
somebody we worked with really closely in other work we've done with the city of Chelsea, where he was the public works director. So that's a nice thing. I think it's great to see the town make such great hires. And, we really, I think he's looking forward to work with all of you and Ade as a direct report. So, new and interesting times,
Right.
but yeah, he's a really, I think he'll do great things in Reading. So, that's a positive. He called me before he was, after he took the job, he's like, "What are you guys doing in Reading?" I was like, "Well, there's a few things." So, so he is aware of this work too. So it won't come as a surprise.
Great.
So if you guys spring it on him, he should know where it comes from. But hey, please let us know if there's any other information. We will send the slides around, so you'll have those
Great,
as a
that'll be
reference as well after.
thank you.
Thank you.
Great, thanks so much. Look forward to seeing the draft.
Yep, mid-March. We'll look forward to it. Thanks a lot, Mark,
Thank
Pat,
you all.
Barry.
Thank you, Mark. Thank you,
Thank you
Barry.
all. Thank you for your
Thank you,
time.
Pat.
Thanks all.
Thank you all.
Guys, thank you all.
Good luck.
Thanks.
All right. So that was good. That was good. I think we'll have a lot to work on this year.
Yes.
I thought it was
Awesome.
encouraging to see that we had already started some of the work and we're heading in the right direction.
Yes.
Yep.
Yeah, I agree. Okay, so moving right along, Reading Coalition, any updates, Kevin?
Yeah, the coalition met last week, obviously, because they didn't meet the month before. There's a good amount of updates. They've really been putting a lot of time in over at the high school with teen mental health. They ran a 6-lesson series that reached 219 students from the 11th grade. And it was workshops all about, all around teen mental health, how to recognize it in peers, how to deal with it on their own, who they can, who they can talk to about it. It was really kind of an encompassing, and from looking at it, very worthwhile. I probably should have shared this with you all earlier, but I'll send out the actual, the meeting agenda. It has a detailed very nicely to all the work that they've been doing over there. Majority of students were going through or knew somebody going through mental health struggles. It was one of the biggest takeaways they had from this series that they put together. Other highlights they had from there, they enjoy the school system is putting more effort into teaching mental health and mental health awareness since it's becoming more prevalent issue. So there's just some of the feedback that they got from the students that went through the program. Learning the recovery position was probably what they identified, the kids at least identified the most helpful. Those that understand what the recovery position is, this is to get somebody on their side in the instance if they're vomiting and throwing up, and how to handle that type of situation. So they really got pretty hands-on with the knowledge that they were giving these 11th graders, which I thought was great. I think one of the comments that they got back was that the time was shorter than they needed to get through all of it. And they actually extended it a little bit past what the program initially had. So I think moving forward, they're going to try to, when they do it again, try to block off even more time to get through all the material that they want to get through. Let's see, update on the clinician position. They still don't have a hiree for that as of yet. I think they said they do have one resume that's in on it, very promising resume, and they're actually trying to boost the position a little bit, or the availability of it out there. So, you know, I think a lot of folks right now are having trouble trying to fill these types of positions. It seems like that's the kind of the feedback that they've been getting. And so I told them, you know, just be very, very active with how you post it. You know, a lot of times sometimes making things too stringent to meet criteria may persuade the right candidate to not even put it in a resume. So, and they're really on top of that. They're kind of, Erica's right on top of that, knowledge of it, and making sure that they can get this position hired as soon as can be. So that's still a wait and see. Some bad news that they had to share. Unfortunately, finding my notes, excuse me. They have to pause. Sorry. They have a brief pause from January 31st through Monday 21st with the William James College Interface Referral Services. This referral service is so inundated with calls, they notified us and said, we have to give you a 3-week pause. We can't take on any referrals from you for this time period, which is kind of, you know, obviously discouraging to hear. Now, it doesn't mean we can't provide referrals to folks. So certainly they're working with other municipalities locally, I think Winchester being specifically one of them, to help get referral services to folks that need it. But that was a little disturbing here. Unfortunately, as you can imagine, because of the crisis going on in mental health, they needed to get caught up. So that will resume on the 22nd of February through their services, but we can still provide those services to people and those referrals to people and moving forward. And they have that on their website, actually. They do have up and running on the coalition website where you could seek out those services and those referrals in the time being. I think that's about it, but I will share this. I'll email this out to Ade to send out to all of you, because it was a fairly lengthy update with a lot of good information in it. Obviously, the majority of it is centered around teen mental health. And that's all I have.
Thanks, Kevin.
Thank you.
You're on mute, Dr. Lopez.
Thank you.
Dr. Lopez, you're on mute. Can I go ahead?
Yes, please. I'm sorry.
All right. Good evening, members of the board and the general public. I'll be giving a general overview of the health department's activities within the past month. Once I'm done, I'll hand it over to the public health nurses, Shuang and Christine, to give us public health nursing updates. In the month of January, we conducted 5 complaint investigations, 1 pre-operational re-inspection, 1 food plan review, 1 well construction review, 5 demolition reviews, 1 occupancy inspection, 5 COVID vaccination clinics, 6 homebound COVID vaccination administrations. Annual permit renewals are ongoing. Both Kim and Don from the Public Health Services Department have been exceptional at making sure that the online renewal process is going smoothly. I mean, they've done an incredible job. It's unbelievable. I'm pleased to announce that the online permitting software is working as planned. Annual renewals are almost completed in record time due to this transition. At this point, we only have 4 establishments that haven't renewed their permits. Food permit is outstanding for St. Agnes Church, located at 180 Woburn Street. Food and dumpster permits outstanding for St. Athanasius Church, located at 300 Haverhill Street. Dumpster and tobacco permits outstanding for Stop and Shop located at 25 Walker's Brook Drive, and food permit outstanding for Hunt Park located on Pleasant Street. Both churches plan on submitting their renewal applications by the end of the week. And at that point, we will be down to 2 establishments that are not in compliance. We are exploring the possibility of levying a late fee for each outstanding permit. And if that doesn't work, we will invite them to the Board of Health meeting for a hearing to discuss why their permit should not be revoked. In terms of health inspector updates, we interviewed 6 applicants initially. We invited 3 finalists for a second round of interviews. Only 2 out of the 3 finalists showed up for the second round of interviews. All finalists were qualified to do the job. At the end of the day, we had to pick the best fit for the position. We offered the position to Jennifer Velasquez, and she accepted it. Jennifer, thank you very much. Jennifer currently works at Stereotech. She has a long-lasting background in food service industry. She is highly motivated. She has a CPFS certificate, which is the Certified Professional in Food Safety Certificate. She is willing and eager to learn new things in the field of public health. Jennifer's anticipated start date is Tuesday, February 22nd, 2022. Regional testing site. So we were able to secure a COVID-19 regional testing site for the Region 3B Public Health Coalition, which includes North Reading, North Andover, Andover, Reading, Wilmington, Methuen, Linfield, Lawrence, and Haverhill. The testing site will be located at the Shriners Auditorium in Wilmington. The COVID clinics, the test clinics will be 6 days a week from 8:30 to 4:30 p.m. And we plan on starting on February 16th, 2022, which is a Wednesday. All residents, businesses, and schools from each community that I listed earlier will be able to utilize this testing site. The one thing we're not sure about is if kids under the age of 2 can get tested at this location. Once I get that information, I will share it with everybody.
Ade, do we know how, 1, we're going to communicate this to the Reading community, and 2, is there going to be a scheduling system, or maybe you haven't got to that detail yet?
So we have somebody working on the information, and they're going to make it specific to each community. So once we get ours, I'll post it on the website, and anybody can go there within those hours and get tested.
Okay.
Vaccine efforts. We all know that vaccination plays an integral role in reducing the transmission of COVID-19. Currently, the percentage of Reading residents fully vaccinated is at 76%, and fully boosted, 50%. We've continued to ramp up our vaccination efforts. In the past 5 weeks, we've conducted 8 COVID vaccination clinics in conjunction with fire and police. Our goal is to see the number of vaccinated individuals increase. We will continue to get residents vaccinated and boosted in the coming weeks. Our next clinic is tentatively scheduled for February 10th, 2022 at the Coolidge Middle School. I am pleased to announce that we have started our homebound vaccination administration clinics. We started it today. We were able to administer COVID vaccines to 6 individuals at home today. We encourage residents of Reading who meet the homebound vaccination eligibility requirements to give us a call and schedule their at-home vaccination. The eligibility requirements will be posted on the website, but at the same time, I would read them out. So you are eligible to get vaccinated at home if you have multiple chronic medical problems or comorbidities impacting your ability to leave your home. If you require the use of a walker, wheelchair, or require special transportation to leave your home. If you are currently being followed by a home care nurse for medical care. If you experience significant and taxing effort to leave your home or require another person to assist with mobility or transportation to medical appointments. And the fifth requirement is if you care for the individuals that meet the first 4 criteria listed and you're not able to leave them by themselves at home, then you're eligible. Lastly, I would like to thank the Select Board for voting to allocate approximately $250,000 of the local and county ARPA grant funds to COVID remediation efforts. This will pay for the rest for the test kits ordered and provide available funding to be used as needed. So thank you very much, Select Board. I will now hand it over to the public health nurses, Shuang and Christine, to give us their public health updates.
Let me just ask, any questions or comments for a day before we move on? Carrie?
You know I do. I just want to. I just want to call out and thank the Select Board for their support and with the ARPA funds. And I want to especially call that out because there are communities in Massachusetts where public health dollars are not making their way to support public health activities, and that is a crying shame. And I am incredibly grateful and pleased that I live in and serve a community that sees the value of public health and sees fit to send some dollars to support the activities.
Great, agreed. Okay, let's move on. Shuang or Christine?
Yep. Hi, good evening. It's Christine. I'll just give a very brief report. This is per Maven. Data is subject to change. It's a weekly nursing report. Date is 1/27/22 to 2/3/22. Total case count is 4,444. It's good to see the number of active cases continue to come down. This is third week, and active number of cases right now is 108. Deaths are at 53. Transferred remains at 16, and number recovered is 4,267. I'm also happy to report that I have no clusters at the present time, and I know that there were some slides attached from school, but I would say the main, what I would like to mention from a school perspective is that the amount of in-school transmission is extremely low.
Okay.
So just a quick highlight. We were at 50 deaths for a very long time. And it looks like in the past couple months, we added 3 additional deaths. I just wanted to emphasize that.
Sad.
Yeah, I mean, that's, you know, in looking at COVID sort of nationally and what the numbers show is that usually the cases come down before the hospitalizations come down, and the hospitalizations come down before the deaths come down. There's a sort of lagging effect. And so these 3 deaths are undoubtedly due to the surge of the end of December and early January. It is unfortunate. Anything else, Christine, or was that it?
No, thank you. If I could just mention one thing, it was really good to hear the report from Mark Fine. And interestingly enough, Shuang and I met with a day this morning to discuss some of the future things that we would like to work on as a department. So it was good to hear their initial recommendations.
Great. Agreed.
Thank you, Christine.
Thank you.
Schwan?
Yep, thank you, Dr. Lopez. I have 2 slides to share. Let me just share my screen. Okay, can you see my screen?
Yep.
So yeah, as usual, I have some, updates with the department. From last December, we have 8 clinics, 5 in January and 2 in February. So we work with Vaccinate RX helmets, and we also offer our own vaccine. So the total vaccination number is 305 doses. 172 are Pfizer, 41 are Pfizer pediatric, 90 are Moderna, and 2 are Johnson & Johnson. And we also received our first order for the testing kits on January the 13th. The total are 288 boxes. And we have started the distribution to other departments in Reading. And also we encourage the residents, if you want the testing kits, you can call us and come to the town hall. Fill out a form, including, the name, address, and then you can pick 1 box of the testing kits. So far, the other departments from, administrative, fire, senior center, public service, Department of Public Works, and library have picked up their testing kits. So the total is 100 boxes. And that's it. If you have any questions.
Just one. Are those the 2 tests per kit?
Yeah, 2 tests per box.
Mhm.
Carrie?
Sure.
Thank you, Shuang. So the tests were purchased, was, just to clarify, was that through your through the FEP coalition? Not sure what you all call the acronym. Is there a regional purchase, or is that a town purchase?
It's a town purchase a day.
So it is
yeah.
a town purchase. So what happened was the town manager reserve fund. I don't know if you remember the budget season. He pretty much gave us $10,000.
Yep.
So the total amount was $86.16. So what I did was I took $5,000 from the town manager's reserve fund,
Yep.
and then the $3,616 was from the health department's revolving funds.
Great.
Thank you all.
Yeah,
Thank you.
thank you. Thank you for doing that. I was just curious because I know some coalitions, there are funds at the coalition level being distributed to support regional purchase of test kits that would augment any municipal purchase. So that was part of my question.
Yeah, thanks, Carrie. I've asked them, but unfortunately, we cannot use that fund to buy the testing kits.
Oh, okay. Interesting.
Yeah. Thank you.
So initially, the state gave free test kits to some communities based on some criteria, and Reading did not meet those criteria. So.
Right. Yeah. No. There was I think it was the 20 the equity communities. Well, no, that's not true. That was different. It was the equity communities plus a couple extras. But then there's also some additional dollars through the emergency preparedness funds that may or may not allocate. Okay, interesting. Can I ask as well? Sorry, I'll just follow on. Shuang, I know you're working with that FEP coalition. Is there any other activity happening regionally for preparedness? You know, tabletops or activity related to COVID?
Yeah, we had a meeting this afternoon, and we, have some like 2,000 something remaining fund, and we are going to purchase some masks, like pediatric masks for distribution for, the region. And also we will have a after action report next week. I think it's on the 9th. So the planner will talk about, the COVID response during the, during the pandemic and for the 8 communities.
Okay, great.
Yeah, and one more thing is I heard a state drill will coming soon. So I'm prepared for that.
Good.
Awesome. Thank you.
I'll be interested to hear about the results of that after action conference. And and also whatever municipal after action discussion and reporting there has been. That would be great to know about for a future meeting.
Okay, sounds good. I will keep you up to date.
Thank you, Shuang.
Carrie.
Thank you.
I want to mention also on the regional purchase of kits. I think the delivery date was unfortunately later than I think we all would have wanted. Did you say early March for
Correct.
the
pilot?
Yes, for the
Yes, we're looking at early March.
early March. But they'll still be worthwhile.
Yes.
Okay, anything else on the monthly report, or we're set to move on? Okay, next on the agenda is what we had said 4 weeks ago that we would do, is to review the mask mandate at each meeting to determine whether it was necessary to continue or not. And so I think Aday has some data that he wanted to share with us, and we can have a conversation about this.
Hi, Jackie. All right, so can everybody see the screen?
Yep.
So I'm going to leave it on there for like 30 seconds for people to digest it and draw their own conclusions. And then I'll just explain it without drawing a conclusion. So pretty much what we did was to compare the weekly COVID cases from October to date with the board's mask policy. So pretty much we compared those weekly numbers to board's mask policy over time. I just want to state that these are cases that have been verified and reported to the state. These cases do not include cases identified by home testing. Okay, and we got this data from MAVEN, which is the Massachusetts Virtual Epidemiological Network. So as you can see, first week in October, we had 29 cases. The board's policy then was a strong recommendation to have masks on. The cases started going up
32, 30, 43, 45. So right around beginning to the middle of November, we started seeing a surge due to Omicron. At that point, we were contemplating whether to implement the mask mandate or not. You know, we talked about how people are getting infected. You know, we talked about household transmission rather than, you know, just picking up COVID from grocery stores and, you know, things like that. But we didn't quite make that decision. And then we still kept a strong recommendation for mask wearing. And then the cases kept on going up. And on January 6th, we finally did a mask mandate. And since then, we've been seeing a downward trend in active cases. So it went from 538 to 360, 196. As of January 24th to January 30th, we were at 98 cases. And we ran the numbers from January 31st, which will be the next line here, but because it's not a full week, we didn't put it on. But the preliminary numbers that we got was from January 31st to February 3rd, we got 54 cases. So the numbers are going down. 54 cases, I don't see it exceeding 98. So it's in line with the downward trend that we've been seeing. And now it appears we're down to pre-Omicron surge numbers. And during the pre-Omicron surge numbers, you know, masks were strongly recommended. Also, we took a look at the MWRA, Massachusetts Water Resource Authority. We took a look at their data. You know, they've been graphing the level of Omicron found in wastewater. And the latest COVID wastewater data shows levels that are nearly back to where they were before the start of the Omicron surge. So this graph is self-explanatory. I know that we have some unknowns. It doesn't actually include tests and positive cases from home testing, which may skew the outcome. But what we do know is the numbers went up. We implemented a mask mandate. The numbers are down back to pre-Omicron surge. So I'm going to hand it over to the board to discuss this and determine if they would like to keep the mask mandate or if they would like to go back to a strong recommendation, or if they would like to keep it for certain entities like the daycares that are not governed by EEC. You know, like whatever the board deems necessary. So that concludes my presentation.
Thank you, Ade.
Thank you. I just wanted to also I've shared this screen before. I just want to, it's similar to a day. This is using the state data, using the 14-day average day incidence, daily incidence per 100,000. So these are the numbers reported from the state since September. And this is sort of graphically watching it. It's very similar to what a day showed from the Maven data. This is a rate per 100,000, so it's a little different. And you know, what's interesting is that you know, this peaked here January 20th, but the decrease over the last 2 weeks has been fairly dramatic. And, at that trajectory, I would think, by next week or the week after, unless something changes, we would be down to the pre-search numbers. So that's sort of similar data. I think that, what makes this decision, there are several factors in my mind, and then I'm going to just open up to the board. What makes the decision difficult is it's not, we're not 100% past this, and it's the data is definitely encouraging. So that's one point. I think, secondly, I think we were very conservative about implementing a mask mandate. It was already peaked by the time we did so. And, we could, rescind it today if we so decided. We don't know if the Omicron variant BA2, which is now in Massachusetts, is going to play a factor, is going to slow the decrease. On the other hand, we also know that our numbers are tracking with the entire state, frankly. None of us are under the illusion that the mask mandate caused that decrease. No, the whole state is going down the same way. And, the masks are just one more mitigating factor. So I think it's not an easy decision. We also know that the mask mandate is something that is certainly an inconvenience to many people, and others feel even more strongly about it one way or the other. So I guess I'd like to open it up and hear from all the board members about their thoughts of where we are, on this and what we feel about it.
I'll go.
I'll
go. No, I thank you all for sharing the data that, and beforehand, having reviewed it. My personal feeling is that I think we can rescind the mandate for sure. How far we go beyond that, I'm not quite as sure about.
Carrie.
Thank you. So, I was pondering this, and I did some comparison of numbers from previous things and kind of considering where we are in active cases, where we are in our, thank you for that info on the rate per 100,000, Rick. And also looking at our 7-day average and kind of looking back in the graph to where we compare to activity in the past. And I have to say that I am not in favor of rescinding the mandate at this point. I think that we were late when we implemented, as you alluded to, Rick. I think that we were very conservative. I think that we were late. I think that to suggest that we take the mask off because the Omicron surge seems to be diminishing kind of misses the point of this is a preventative measure. It's not like an antibiotic that we give and we eliminate the source of infection. The masks are a preventative measure that we're implementing, and that's what I look at. And I will observe that when I looked at the graphs for the 7-day average, our current 7-day average on February 2nd, 2022, the 7-day average is 5,666 cases. I went back on that great line chart to find a comparable peak, and what I found was January 11th, 2021 was 6,351 cases. So yes, we've made a huge improvement from that peak that we were experiencing the beginning of January, but We are approaching February vacation where there's lots of activity of people sharing space. I think that I would attribute the lack of in-school transmission to the presence of masks, not the absence of disease. And so for all of those reasons, I am not in favor of rescinding.
Kevin, you had your hand up?
Yeah, I've thought long and hard on this, and with all respect, Carrie, I feel the opposite. I don't see how you actually could, with the data in front of you, continue the mandate. Like literally, all the data that's in front of you is saying it was okay for this to be at these levels back in September, October, November, but it's not okay now. That's contradicting itself. So the latest data that we have from the wastewater BioBot actually has us back in September levels. That's what it's showing. Now that's taking into account not only everything that Maven has, that's taking into account all the home tests that people didn't report or people that didn't test at all. That's taking everything into account. So to look at that data point and say, if in September we were fine not to have a mask mandate, but today we should have one, is very contradicting itself. So I don't think you can do it on that basis alone, but I'll also go on and say further, a month ago, I made the same point. You have a mandate in a place where the transmission is not happening. Plain and simple. It's happening in the home. We know that very well. It's not happening at the grocery stores. It's to any measurable level. And that's all the data that we have. So I've always felt all along that I understand a lot of people feel more comfortable being out in public and having everybody be masked inside. And quite frankly, I saw 75% of the population was masking inside long before our mandate. I don't expect that to change if you rescind the mandate. But to say you want to have a mandate in places that the transmission just simply isn't happening, I think is the wrong course of action. I've always felt that the Board of Health has an obligation. If they're going to do something like a mandate, they really should be able to qualify it and quantify it. And there's no way to do that with this. And actually, the data says that, you know, where it's being transmitted is not where this mandate is going to land. And for those reasons alone, I can't see how the board could continue to go along with the mandate.
Jerry.
Thank you, Kevin. And I don't have to go now, but I just want to make, I would
Sure.
like to make a point of clarification if I may.
Go ahead. Go ahead.
Okay, thanks. So two things, Kevin, and people can agree to disagree and people can disagree agreeably. I appreciate the perspective of everyone. But I do want to make 2 points. And one is that the numbers that I'm comparing to, we are not at the levels of September and October yet. And that's exactly the reason that I'm suggesting that we would need to maintain it. If we were back at the numbers for cases of that level, that's where I would, then I would agree. But we're not there. We're still comparable and slightly exceeding to where we were in December. So that's the first one. And the second one is, and I said this at our last meeting, that the issue about transmission and where transmission occurs. So when transmission occurs in the home, it's because someone's been exposed outside of the home and they've brought it back inside their home and have exposed family members in instances where they're not masking, because people don't mask inside the home typically. So the act of wearing a mask outside of the home prevents or reduces the likelihood of bringing of exposure and then of bringing the disease back into the home where we're causing, where there's a likelihood of transmission. There's a higher likelihood of transmission. And sorry, just last thing, I think that one of the challenges of public health is that it's very difficult to quantify prevention. And, you know, that's our job. Our job is prevention, and the absence of disease and the absence of, you know, other environmental factors, things like that, that's a real challenge. And that's one of the things that draws me to public health, is that it is the beautiful mix of quantitative and qualitative, and the application of the science. So I just thank you. Thank you for the opportunity to clarify my points.
And just again, Kerry, that was from the MWRA reporting going back to September levels. Now, I understand that's a forecasting tool as much of anything, but this is not just looking at the data that Rick had put up. Again, this is the data that point when we saw that massive spike on that report. I think that kind of opened everyone's eyes up to say, oh wow, this is getting out of hand and fast. But I can't see continuing on with a mandate, again, for a couple of reasons. One, because of that report, that singular report. I'm happy to pull it up if you haven't seen it yet. As well as I know it's tough to quantify, but we can easily look and see that it's not happening in the places that we're mandating it. I think that's pretty clear with the data that we're getting back. We actually have real data that says, no, that's not the major source of it. So I have a hard time doing something that's in effect doesn't have a lot of effect to the outcome we're looking for, which is to stop transmission. I just don't see it happening. I don't think it happened a month ago. I don't think it's happened since the mandate's been in place to any measurable effect whatsoever. Because of that, I just can't see a Board of Health continuing along with that mandate.
Kerry, thoughts?
And again, I just go, it's not that that transmission is occurring in the outdoor settings. It's that, to your point, what we're talking about is exposure in settings. If you're in a 15 minutes or longer and exposed to other people, we know that Omicron is a more contagious variant, and it is it's about preventing the exposure and illness, and then bringing it home to increase the number of cases through household exposure where folks are not by right not wearing masks.
Yeah, one thing I've said all along, and I actually was on record saying this early on in this pandemic, we're going to have to learn to live with this. This is not going anywhere. I mean, this is not going to change anything. We're talking about yearly inoculations. This is going nowhere. And so to try to prevent an upper respiratory issue from spreading, as you know, historically has never worked. It just never has. It never will.
Disagree. I mean, there's examples actually in Toronto, SARS-CoV, that was actually they were effective in preventing the transmission. So, and Kevin, I don't want to, I'm not sure that it's productive for us to debate. I think that we're both pretty clear on where we stand. BioBot is very interesting. Yes, I look at BioBot, but that is not where I or where public health professionals are making their decisions using BioBot. It's a factor of information, and it's very encouraging to see that the numbers have gone down, but that's not a sole source of data.
No, but it should be one of the biggest sources of data. It encompasses everything, and it's not just taking into account testing, it's taking into account everything. People that haven't tested, people that tested at home and didn't report, it takes all that into account. It should be a huge data point. That disturbs me to hear that it's not a big data point in the medical world. Really,
I can't speak for others, but I will say that BioBot is one factor, but I'm not making a decision based on the fact that BioBot has gone down.
Okay, we'll have to agree to disagree.
That's right, and I'm happy to do that friendlily.
Can I ask some questions and maybe offer something else to think about? So one of my questions is, and I don't know if anyone has this data, but what was the compliance with the mandate? Did we see an increase in mask wearing? I mean, kind of to Kevin's point, did it fall out as people who were going to wear masks wore masks and people that weren't were not, even after the mandate?
I don't know if we have any specific data on that. I mean, I certainly, my anecdotal experience at Market Basket is that the last 2 times I were there, there was a handful of people, 4 or 5, who were not wearing masks. And the other 100 or 2 that are in that large store were. And I also noticed the same at Home Depot, but that's my own personal experience. I'd ask Ade, did the health department receive in the past month any complaints or, from residents about businesses that weren't complying or, seeing a lot of unmasked individuals?
Yes, we did. We got about 6 to 10 complaints. We actually had somebody from Market Basket call and said they were told to not implement the mandate, that the management asked them to not implement the mandate. We got several complaints from Market Basket and Stop and Shop. And then
Complaints of people saying that there were individuals who were not wearing masks in that.
Correct.
in businesses.
Correct. And we got complaints from Dunkin' Donuts on Main Street about somebody that goes there every day and never wears a mask. And the mandate gives exemptions to
Right.
people that have upper respiratory diseases, or they cannot wear masks. And we can't go there and ask him to show his medical record, or we can't do that.
Yeah, sure.
So, I mean, I would hope that compliance did go up with the mask mandate. And my fear is if it didn't, with the data we saw last month, I worry about now, right? With this current level of data, that people will completely disregard it. I think the one thing that I'd love to do is I'd like to help people understand that masks do work, especially if you wear the right mask. I mean, we talk about in-house transmission. Masks would help in that situation if we wore them. So I do hear a lot that masks are useless. And I don't think that's true. I do think you need to have the right type of mask. But I think that's a really important point, whether there's a mask mandate or not. I mean, if we don't have one, we're still going to have a strong recommendation to have a mask of a certain, level, K95 or higher, right? So I think that's making sure we communicate that to the public, that masks do work when you have the right mask is still important.
I can speak to going to church, and everybody is wearing a mask at church. They're not all N95s or KN95s. Some of them are the cloth masks, but everybody is masked.
And was that the same in December as it is now?
It was reinstituted in December.
Okay.
So the other thing I would say too, I know Beverly just rescinded their indoor mask mandate as well. And
I'm sorry, I didn't catch that.
Beverly rescinded their
Beverly.
mask mandate.
Yeah.
And also as well, when you look at Middlesex as a whole, and I haven't in a while, so I won't quote exact percentages, but it was a high percentage of fully vaccinated individuals in Middlesex County and the surrounding counties for that matter as well too. I'm sure that those numbers have probably gone up since I've looked at it a few weeks ago, but again, so I won't cite it, but I know it was over 70% at the time. I want to believe it was 76 at that time. Again, I look at too many data points that say, 1, it's not effective. And 2, if it's not effective, why do it? I can't get over those 2 simple points. And when I say effective, did it stop a transmission? Maybe. There's no way to tell. There's a good way to tell that. Again, it was highly unlikely that was the source of the spike, is being inside grocery stores, convenience stores, restaurants. We know that wasn't the reason that the number spiked as it did. I just find it hard to continue something that we can't, whether you think it's effective or not, I personally don't, but we can't qualify that.
What about early childhood? I mean, we did have a lot of spikes and now we have no cluster. So to the math, I think that is one that we should consider.
mean, there are many studies out there that have shown that masks are effective on a population basis with COVID over the past year. And if you go to our website, and one of the questions about FAQs, why wear masks, there's a link to a CDC scientific review that has 90 references about the effectiveness of masks. We also know that in countries like Japan, that it's just cultural and they wear masks every winter because that's what they do around the influenza season, that they typically have lower rates of influenza than in countries that don't, which is most Western countries. But that's just another point. I don't think we could say masks do not, I mean, the scientific evidence is not that masks do not work. So I just, want to make that point. Go ahead.
And I wasn't saying that masks don't work.
That's what it sounded like.
No, what I was saying is that where the mandate is, the transmissions aren't happening.
Right.
It's not that masks don't work. The correct mask worn properly obviously works very well. That's
right. I think the issue of where the transmissibility occurs is really not, the transmissibility happens in the home because once COVID comes into the home, no one's wearing a mask. Everybody's using the same towels, the same, they're breathing the same air for hours on end. And of course, everybody else gets it, or many can get it. But it isn't that you need to wear masks in the home, although it would help. It's that someone brought the virus into the home. And I think it's similar in the school system. What we've seen is that when Mary has reported on defined cases of in-school transmission, it's actually very low compared to the numbers of COVID. And that's because, they're wearing masks and they're not getting COVID there. They're getting it at home because it's being brought in from the outside, other places. So I think that pattern does make a consistent logical notion for wearing a mask. I would say that, obviously it is true, Kevin, and I would agree that we're always going to have COVID. That's not going away. And the question is really at what level of activity is kind of acceptable, because otherwise we'll wear masks to our deaths, and that's not going to happen. And so what level of activity is an acceptable level? This board last fall, thought that, that this level here in September, October, November, was an acceptable level, even though the CDC defined that as, moderate to sustained transmission. But we said, you know what? It just is not that high. It was when it got here into December where it's up. Now, I think what Carrie was referring to was this, and these numbers parallel kind of what Ade showed, that yes, it's coming down, but this number is nowhere near what these numbers were here. So I don't think it's inconsistent to say that we're almost there, but we're not there yet. Even if you look at these numbers here in early December, they're not at this level of transmissibility. Paula.
Just one more point about whether or not masks work. If you recall last winter, now we don't have the numbers for this winter, we had 2 reports of influenza.
Right. right? That's another example of that. And actually, mask wearing is, although we don't want to get into scope creep, but one of the secondary benefits of wearing a mask is the reduction of influenza, which also kills people as well, although not as intensely as COVID.
But depending upon the year.
Right, right. Yes, Carrie.
Two things. I was just looking to see where we, I had made note on our percentage vaccinated, because that came up earlier in the meeting. The community is at 76% fully vaccinated, and that's either 1 dose of the Janssen or 2 doses of Pfizer or Moderna. We are only at 50% boosted, and that is the difference maker, because what they found is that the 2 doses or the single dose of the Janssen are not as protective for transmission, and the boosting is the lack of boosting is a vulnerability. I really can't emphasize enough the importance and value of folks obtaining a booster dose of their vaccine, because our goal is to prevent illness, and that is, that's been shown to be a way. It certainly prevents deaths, it prevents severe illness. I know anecdotally from my work that the instance of folks being hospitalized for COVID during this current surge, they are typically not boosted or not vaccinated. If they have been, there are other significant comorbidities that are impacting their vulnerability to the illness. So that's the one. And then just looking at where we stand in our county data, we're still in the what CDC calls is high transmission, and high in those standards, that is mask wearing. So I think that those are factors to consider.
The other sort of data to consider is the percent positive tests, which during the peak of the surge, Reading was running at about 25%. And the data as of today from the state, it's down to 11%, which is about, the state is running as a whole at about 10.5%. So we're right at the state level. So that's an encouraging piece of data, as well as the BioBot data and the general decline.
And my general feelings is, if you were to rescind this, I think 75% of the population will still wear a mask indoors until the spring. That's what we were seeing generally before the mandate was put in. And I don't think if you rescind this, you're going to see numbers go up. I think you're going to see that trend continue to go down. If anything, I bring it back to, yes, if somebody brings it into the household, we know that's where the transmission is. And if we stop it from coming into the household, I understand that. I don't think you can, quite frankly. I don't think it did over the last month. I don't think you stopped it from coming into the household. Not on any large enough scale that it matters. Not large enough to mandate an entire town to wear a mask indoors. I just don't think, I hate to use a simple phrase, but the juice simply wasn't worth the squeeze. You pulled the lever and it just, I don't think it did anything. Just being honest, I really don't. I don't, as what you said earlier, Rick, none of us on the illusion that because you put the mandate in place, that all of a sudden the numbers started to surge down. And well, it was just, if anything, Kerry, one thing I agree with you, probably we're late to the game. I hate to agree with somebody who brought that up earlier to us, that maybe we should have done it in early December. Maybe it wouldn't have spiked as much as it would. Who knows? This variant, though, it was, as you said, it was so and continues to be, but it was very transmissible. That was evident, and it didn't seem like masks were going to do much, especially the cloth masks that we found out now. Really didn't do much, if anything at all, to help that. So, if anything, you might have been a little late to the game. I wouldn't be late to the game to drop the mandate either. I don't think that makes much sense. Again, all the data that we have right in front of us, and that's really the best thing you can go off of, shows that downward trend. If nobody's with me in believing that where this mandate is transmission points, I have no data to back that up, but you can't possibly qualify it one way or the other, and that's the only reason. But it's just from seeing how the population reacts and where these households are getting it from. Obviously, that was the biggest surge. It was the holidays. Certainly, it was New Year's, and I know there's going to be other dates coming up. There's going to be February vacation. There's going to be April vacation. I just think you need to leave it up to a person's personal preference moving forward. And I think the numbers dictate that you can do so. I don't think you're going to move the needle by continuing to have this mandate. I don't think you're going to do anything with it. And again, I come back to, as a board, if you're gonna mandate something, it should move the needle. It really should. There should be something that we can point to and say, yeah, look at this. This is real and quantifiable. And this isn't the case. It just simply isn't. And I'm sorry that I keep.
I would just
I feel strongly about it.
Yeah, I know you do, but I would also say that there are about 30 communities in Massachusetts that have mask mandates. And in the past year, there have been whole states that have had mask mandates. So I would not look at a mask mandate as a capricious and unfounded thing. It is definitely a tool. The question, I think, is where and when do you need to apply that tool? And so that's an issue. The other thing I would just say is that we may have been late to the game in getting the masks. I'm a little concerned about being early to the game in eliminating the mask, really actually potentially from a public perspective. I mean, there's been a lot in the news in the past year about the society's trust in public health because of decisions that were made and then changed and then changed. Now, some of that is just the science. We're learning as we go along and things had to change. But some of that has to do with, the public's perception about, do we make decisions? Now, you would say, we have no evidence. I would say we do, but there's also this unrelated issue of being capricious and unpredictable in terms of mandates. And so I have a concern about that. Yes, Carrie.
And that's I just say, and that is one of the key points for my not wanting to lift it at this point, because where we are is higher than where we were. And thank you for bringing that, so I could see it was December 30th was when there was 70, I think it was 70, yeah, 70.3. I wrote down the number of cases, and we're right now at 75.4. So we're not lower than we were at December 30th when we were contemplating putting in a mask mandate. So I'm not comfortable saying, well, 70 was problematic, but 75 is okay now.
So what I'm a middle child, so I'm very skilled at negotiating, the in-between position. So, one possibility could be to, from my perspective, it's a little bit premature. I think we're going to get there relatively soon if these numbers keep going down. I'm just concerned that if we rescind the order today and the numbers continue to trickle at the same level for whatever reason, or whether the BA2 variant, makes a foothold, that I don't want to come back on March, whenever our March meeting is, and have to reinstate what we rescinded. And, I know that boards maybe do that, but it just seems to me to be too inconsistent. So, so there's a couple options. One is, actually there's one option, which is, we could agree to reassess this specific mandate in 2 or 3 weeks, rather than waiting a whole month for another review. And if the numbers in 2 weeks, let's say, or at least the numbers that, whether it's a day's graph or my graph, if the numbers were to come down into this range, then in the pre-holiday season here, which, they very well should, if everything keeps trending the same way, then maybe we rescind it and not, continue to use what I do agree is an overbearing, it is an overbearing thing to have a mandate, but if you believe it, that it's an effective tool. Then we could come back in 2 weeks and for a special meeting just to address this one issue, to relook at the numbers. And if the numbers are down into this range, then we could all feel comfortable that, yes, we made it, and this is not, we've done what we needed to do. So that would be another possibility. Paula.
So Carrie made a good point about talking about February vacation, and 2 weeks is just before February vacation. And historically, it's been right after vacation times that we've had an increase. So I'm not sure if 2 weeks is going to be a good option. I think we have to, if we're going to do this, we do it to the next meeting.
Which would be March 3rd.
Yeah. By then we'll have a sense of what impact February vacation has had. People are going to travel to other states, to other countries, and they're going to have encounter different rules and regulations in each of those places. And then whatever happens there is going to be coming right back here.
Okay. I don't know if I necessarily agree with that, Paula. Just on the idea of, we don't know what people are going to do. We can't, we're not in the business of trying to predict what people are going to do. We can't, it's not reliable. There's no
We're
source
in the
information
business
for
of
that.
trying to prevent what people, the ill. We're in the business of prevention, not
Yeah,
predicting.
and I think we've done a great job. I think even though we're at 50% boosted, I still think that's a good number. I still think the number of percentage of people that are fully vaccinated or doubly vaccinated, if you will, is shows that people took this very seriously. And at some point, you need to learn to live with this thing. I keep bringing this up. I've brought this up for nearly 2 years now. This is not going away. You can't, every time a holiday comes around, we can't just keep instilling a mask mandate. Again, if you showed me something that says, look at this great point of information. It shows specifically that a number of cases went down as a direct result of the mandate because of where the mandate was put. That's great. I mean, that's what you're looking for. You're looking for source of information like that. There is
I
no
think
such
Ade showed us at the last meeting. Ade showed us some comparisons of mandates in different towns, and it did seem to indicate that it was helpful. I won't say it was
So
like
the one thing I
a
will say
wow
with
moment, but
the one thing I will say with data, you cannot look at 1 point. You can't look at 2 points. You need to look at hundreds of points if you really want to make sense of it. You can make it dance however you want. I look at data all the time. It's very easily to manipulate it. It's very easy to fall into one data point and drive with it, but it doesn't give you a full scope of what was going on in the town. The town, you need to look at a lot more than just that one. That there's a lot of factors that go into how can we actually look at this information, decipher it, and come up with a good conclusion. We don't know if there was more testing in that town, and that's why the numbers in one town and numbers are higher than another town. There's a lot of different factors that will go into it. Again, I would just look at what we have in front of us right now. And I know, Carrie, that you don't put a lot of stock in that BioBot. You use as one data point. But I think it's one of the best data points we have and one of the best tools we have as a board at our disposal. It's a predictor of what we're going to be looking at. And I can just share, I'll bring this up here quick. Why are you saying I can't do that? It's fine. No, because I probably didn't authorize it. Okay, so I'm not going to bring it up, but that BioBot data has it as a projection towards the end of this coming month, all the way back on the same line that we had it in September, actually under in some instances. So I know that's only one data point, but that shows a clear direction of where this thing is heading. And I can't get past that. I think a month is absolutely too long. If you're not going to rescind it tonight, I think you should talk about it again next week. And then if not, then the week after that. I think you should be looking at this thing as a week over if you're not going to do it tonight. But I would actually say tonight, you should do it. I think everything's telling you that you can do it.
This is, I'm going to share, I want to just share this slide that I think someone, maybe Paula, you were referring to. This was from one of my earlier presentations, looking at 25 communities with a mask mandate, and 18 communities in the surrounding Reading area. And what you can see is that the average daily incidence for those communities that have a mask mandate was much lower than the surrounding Reading communities that didn't. It's obviously not a one-to-one, it's not a graph, it's a splay, it's a data spread, but it's suggestive. And it's only another example from those 90 references of studies that have shown it to be effective. Why don't we, I don't think we need to take a vote on this because the vote would only be to rescind, and I don't think there's enough support for that. But I think Paula's point taken, but this is an important issue for the community, that maybe we ought to plan a brief meeting on the 17th just to discuss this, see where it is. We will be just before the holiday, the school vacation. I think school vacation is the week of the 21st, President's Day week, yeah. But we could at least relook at the data. If it's, maybe it'll have plummeted down to such a low number like September, October, and we'd feel comfortable that even a vacation is not going to be an issue. Maybe it'll show that although what we're looking at it now is a dip down, now there's suddenly some trend up and we need to sit tight. But at least acknowledge that this is something we need to really stay on top of. And so I propose that we plan to have a brief meeting on the 17th to relook at, and I would ask a day to update that chart for that meeting. And I'll come with my graph and we'll see where we are and go from there.
Can I ask a quick question?
Yes.
Has anyone looked at any of the surrounding towns to see if they haven't come down as fast as we have? Because none of the surrounding towns have it. Stoneham, the one exception, I think they have it in grocery stores or some.
I think Stoneham has a limited mask mandate for grocery stores and pharmacies. Wakefield has an indoor mask mandate like us. And the other surrounding towns have a municipal building mandate, but nothing more than that. And I think actually Woburn doesn't have anything. And their cases are actually pretty high. So that's, but you know, do I have a similar graph in terms of what the trend
I'm curious
has
to
been?
see.
So,
Again, it sounds like you all the belief that if the mask mandate stays in place, that it will affect change. I have that correct?
Mhm.
Okay. I think
Yeah.
that's just where we disagree.
So I think, you know, I kind of enjoy putting together Excel spreadsheets. So yeah, I would be
Have
happy.
fun with that.
I would be happy for the next meeting in 2 weeks to look at those towns that are contiguous to Reading, and in terms of, or maybe even ones that, since it's only Wakefield that has it, may be looking a little bit more, maybe 2 towns over, and trying to see what their trend has been over the last 60, 90 days compared to our trend, and mask versus non-mask mandate, and just see what those numbers look like.
Thank you. I appreciate that.
That's great.
Yeah.
So I
And I'm
think
happy to
think
meet on the 17th.
the
Yeah,
7th,
I just want to say that I appreciate everybody's efforts here. I mean, we may not all agree,
Mhm.
but we certainly are putting our community first and foremost here. And I think we ought to pat ourselves on the back for that.
Right. Absolutely, and I think everybody has clearly has given this a lot of thought, and this is not something we're working on that's, you know, that we're not deeply looking at the information.
It's
and
not
trying to
frivolous.
make our best judgment.
Yeah, we're not treating this frivolously.
All right. In terms of the next agenda item, I don't see there was a request by this business Simply Fit and Fun for a waiver, and I thought that they were going to come to present their request, but I don't see them in the audience. Do you, Ade, do you see them?
No, I don't. I can send a quick email to see if they'll show up.
Yeah. Well, I think we should defer that until, I mean, if they do want to do a waiver, we could add that to the 17th, but I think we've given the time and so forth, and we still have public comment. We should move on. So in terms of the public comment section, I do see some members of the public in the audience. We're going to follow the same guidelines we did the last 2 or 3 meetings, and that is that we will, if you have an interest in making a comment, at the bottom of your Zoom screen, there's an icon that says reactions, and you should click raise your hand. The system will keep you in order of when you raised your hand, and then we know to have you to speak. When you come on, you will have 2 minutes, and please give your name and at least your street. If you don't have to give the exact street address, but at least your street, so we know you're a Reading resident. And so,
Do you still want a 30-second warning?
yeah, Jackie, if you can be very assertive around that, that would be good. So there was a hand up, but then it went away. I don't know if Narcissa wants to speak or not. Yes, okay.
Hey, Narcissa, you can go ahead and unmute.
Hi, gosh, this vote almost went properly, so I wouldn't have had to say what I'm going to say. And thank you, Kevin, for your input. Thanks for your time and the opportunity to speak today. I actually didn't want to, but the strange and unfortunate outcome of last month's vote on the mask mandate left me no choice. During the last few weeks it has been in place, it is easy to see the pall that has enshrouded our town and the anxiety it further instills in an already tense environment. The mandate was put forth by the committee despite vast amounts of information proving its inefficacy and the physical and emotional harm it inflicts on human beings. I had forwarded additional information to the director a day, and that was not shown on his misleading presentation at the follow-up meeting, despite its relevance. And while that is a violation of omission, the matter is more serious than that. The members of the Board of Health, whether elected or appointed, take an oath of office that includes the promise to faithfully uphold the law of the Commonwealth as well as the Constitution of the United States. Implementing any mandate that contradicts either the Commonwealth's Constitution or the Constitution of the United States is illegal and would therefore violate that oath of office. The mask mandate contradicts several Massachusetts and federal laws. Massachusetts Constitutional's Articles 4 and 7, Mass General Law, Section 13A, United States Constitution, First Amendment, Fourth Amendment, 14th Amendment, Section 1. If
30 seconds.
If the board does not vote tonight to rescind within the next 48 hours with a deadline no later than the 17th by which it is implemented, I will, along with a host of others, be filing a claim against the board's surety bonds, otherwise known as fidelity bonds, otherwise known as liability bonds, which will apply to each violation separately. Thanks for the time.
Thank you for your comments, Narcissa. Any other comments? Mike Moynihan?
Go ahead and unmute
Yeah.
Mike.
Yeah, hi, can you hear me?
Yep.
There's a rumor floating around in town that you have a Board of Health inspector that has a metal badge that resembles a policeman's badge that was flashing around Market Basket. Is it true that the Board of Health inspector for Reading has a metallic policeman style badge versus paper credentials?
Dave, do you want to respond to that?
No.
That is not true.
So I can comment further on this if you would like me to.
Please.
Yes, please.
So a lady came to the department a couple of weeks ago, and she said that she was at Market Basket. I don't know if I should be discussing this because she wanted to speak with me in private, but since you brought it up, I think I'll just talk about it. She said that somebody approached her at Market Basket and put a badge, flashed a badge right in front of her face and stood there for 45 seconds. And then the person walked out, ran out. So I had no idea who it was. She had mentioned that somebody named Dennis. So I did my investigation. It is true that we have a third-party inspector named Dennis that does food inspections and some other inspections for us. It is true that Dennis was present at Market Basket on that same day that she made the complaint. I called Dennis and I could not independently verify the chain of events that occurred as the lady stated. When I talked to Dennis, who is the third-party contractor that does inspections, he confirmed he was at Market Basket, but he gave a totally different account of the chain of events. He said he was a Market Basket for a different reason, to look at some bird drop-ins, and he saw 5 people standing without masks. So he went and approached them and told them, good afternoon, I work for the Board of Health. And he said he showed his badge. And then he said that, could you please put your mask on? So that was what the third party told me. We didn't give a third party inspector a badge, a Board of Health badge. From what I understand, it appears that the inspector works for a different municipality that may have provided him a badge, but the town of Reading did not provide the third party a badge. He's not an employee of the town. He's a third party contractor. The lady that called, her name was Amelia. I reassured her that, we don't condone that type of behavior in Reading, and that we treat our residents with dignity and respect. I let her understand that, this person is a third party inspector, that we will no longer be needing his services in the nearest future. And she was fine with that. And then she made a comment about, if I can give her information about his bosses at other municipalities, that she wanted to contact his bosses at other municipalities. I told her I didn't have that information. He's a third-party contractor that does inspection work for the town of Reading. Amelia also went to the police department to file I'm not sure if she did, but I know that she went there. I don't know if she filed a criminal case against this inspector. I know she wanted to get a warrant to get the video recording from Market Basket. I don't know how far, I don't know what the outcome is, but I reassured her that we don't condone that behavior in Reading. We treat our residents with dignity and respect. And I let her understand that this person, third party, his services would not be needed in the nearest future. And, again, as I stated earlier, we hired an inspector, a permanent inspector for the town of Reading, and she starts on the 22nd. And once she starts, we will no longer need the help of a third-party inspector.
Thank you for your detailed response. I appreciate it. And it sounded like you handled it, in my opinion, it sounded like you handled it the right way by dismissing this individual. So thank you for that.
Thank you, Michael. Okay, in the absence of any other hands up, I think we can move on, actually kind of wrap up. I think the plan is to have a brief meeting on the 17th to reassess the mask mandate and look at the data one more time. I think that, a day if that business wishes to come forward and have a discussion, they can come to that meeting. And I guess that is it. Any other last comments or suggestions? No. Okay. Well, this was fun. Let's do it again in 2 weeks. Motion to adjourn.
Second.
Second. Roll call. Carrie?
You're
Paula?
muted. Yes.
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 Yes. And yes. All right. Thank you, everybody. Appreciate
Thanks.
your effort. and
Thanks,
your-
everybody. Yes, definitely. Appreciate you all. Take good care.
Have a great night.
Good night.
and